Hello everybody, welcome to first part of approach to antibiotic uses. In this first part, we'll be talking about general approach to antibiotic uses. So let's start with the disclaimer. This video is intended solely for the education purpose of fourth year medical student. This should not be used as a direct source of reference for making clinical medical decisions. The learning objectives of this lecture are discussing about history of antibiotic, including the lessons learned. Then we'll be talking about antibiotic resistant crisis, why using antibiotic optimally is more critical now than ever before. We will be then talking about general framework for approach to a patient with possible infection. Then in second part, we'll be talking about clinical themes, talking about different infections. And then third part of the lecture would be clinical reference of individual antibiotics. Let's dive into it. So let's discuss about history of antibiotics. People identified some active chemical substance in moldy bread. It was a long time back in ancient world. Then in last 100 years, antibiotics have drastically changed the modern medicine. One of the wonders of medicine, I would say. It has extended average human lifespan by 23 years. So it's one of the biggest invention, I would say. In 1909, Paul Ehrlich, he discovered salvarsan, and it was used for treatment of syphilis. Then Prontocil by Gerhard Domach. He's a bacteriologist, and he used that to save his daughter's arm from amputation. In mid-20s to mid-60s and even later, people were researching on different kind of fungi secreting the active chemical substance, and these were called antibiotics. And these were considered fancy, and there has been a lot of discovery in that time frame. So starting with Alexander Fleming, 1928. So this guy, Alexander Fleming, was kind of careless guy. It was late to September. He was getting late to go for vacation, and ultimately he left for vacation. In a hurry, what he did, he left all these staph colonies in his lab all over the place. And when he returned from the vacation, he found that his staph cultures were messed up. So his staph culture were contaminated with the dripping water. As you can see in this slide, this is the original slide from Alexander Fleming. So the part of the culture media where the water was dripping, all the bacterial colonies were all gone. And then farther away from the dripping of water, the colonies were intact. So it didn't take him a long time to understand that there was something in that dripping water that was suppressing the growth of the bacteria. And then he collaborated with other scientists to isolate that fungus, which was Penicillium notatum. Um, then there was a fire in Boston in 1942, and it was hugely successful. The penicillin was hugely successful in uh, preservation of that graft, skin graft, preservation of staph infection in those cases. So, and then that was a triggering moment for U.S. government to support mass production of this medicine. And then 1944, it was used in troops, both in fields and in the hospital, and in World War. It saved millions of lives, and that's why penicillin is called wonder drug. Alexander Fleming then collaborated with two other scientists called Florey and Chain to develop mass production of penicillin. And all these three people were awarded Nobel Prize in 1945. Then when you're talking about antibiotics, we cannot forget the name of Selman Waxman. This is the guy who started systematic study of microbe um, in the production of antimicrobial compound in 1930s. You can see the picture on the right side here. So he identified actinomycetes as a prolific producer of antimicrobial compounds. Look at the bottom, how many antibiotic we get from actinomycetes, and the credit goes to him. He won for this reason in 1952. He was awarded Nobel Prize for discovery of streptomycin. Um, so in this era from 1920s to 1950s, there was a rapid and relatively easy discovery of multiple classes of natural product antibiotics during a relatively short period of time, and that actually led to excessive use of these medicines in that time frame. So antibiotics are called a miracle of modern medicine, and the reason is, as you can see here, different infection, community-acquired pneumonia, pre-antibiotic mortality was like 35%. It went down to 10%. So look at the difference in a different infection it has brought. So that is the reason why antibiotic is considered miracle of modern medicine. That era. So if you look at, from the first discovery to now, a lot of things happen here. Too many antibiotics in short span, and people used antibiotics. And then one of the frightening thing I would like to tell you this here, 1987. That is the time when last class of antibiotic was produced. That is adaptomycin. That's the last class of antibiotics. So no new class of antibiotic being discovered after 1987. So why there is no new discovery of antibiotics? Because there is no money. If you're talking about hypertension, if you're talking about diabetes, you have a patient who are going to take those medicine for the rest of their life. We are talking about antibiotics, we are talking about infection, and you are going to treat infection for just for 1 to 2 weeks, and the current trend is to reduce the duration of antibiotics. There is no money in antibiotic business anymore, so that's why we have not invested in discovery of antibiotic, which is very, very unfortunate. But that history has taught us a lesson that we need to be very careful. We are running out of resources. We have used too much antibiotics, and too much exposure of antibiotics to the bacteria is not a good thing. These bacteria, they are smart. As you can see here, the one in the bottom, that is a date of discovery, and the one in the top is the date of first, date of resistance being identified. So if you look here, you can see a pattern. After each 5 years of antibiotic discovery, you can actually see there is a first, reported resistance. So what does that tell you? That tells you that these bacteria are smart enough. So it's high time for us to understand we are running short of resources, and we have to maximize. We have to limit the use. We have to maximize our resources. So we have to keep it for the future uses. So let's discuss about harms of antimicrobial overuse. So number one harm is antimicrobial resistance. Single additional antibiotic treatment day increases the risk of resistance carriers by 7%. So in the United States, more than 2.8 million infections and more than 35,000 deaths per year has been attributed to antimicrobial uses. So that is one death every 15 minutes. And this prevalence has been estimated to go up to 10 million by 2050. So that's a big number. Then number two harm is rising C. diff rates. 223,900 admissions, and then 12,800 deaths per year attributed to C. diff. And these deaths are not included in above death. And then number three harm is adverse drug reaction. Almost 20% inpatient report adverse drug reaction, and almost 20% adverse drug related ER visit are attributed to antibiotics. What are the cause of antibiotic resistance? According to WHO, overprescribing of antibiotics, patient not finishing their treatment, overuse of antibiotic in livestock and fish farming. Remember, tetracycline is used as a growth hormone um, in animals. So that's why tetracycline does not really work in enterococcus in human. Poor infection control in hospital and clinic, lack of hygiene and poor sanitation, and lack of new antibiotic being developed. So we're running a race against time to keep antibiotics working. What can we do? You might have appreciated the recent trend in infectious disease. The trend is to limit the duration of antibiotic, and you know um, we are going away from use of fluoroquinolone for the same reason. We are limiting duration of treatment of antibiotics for almost all the infections. So what else can we do to solve this? The answer is antimicrobial stewardship, which is practice of utilizing optimal antibiotic, including dosing, including appropriate duration, and route of administration. So what they found is we prescribed ton of antibiotic. In outpatient world, there was 255 million antibiotic prescribed in 2024 alone. And then what they found, according to CDC, 28% of those antibiotic prescriptions were unnecessary. In inpatient world is even worse. Almost 50% of admitted patients they get antibiotic, and then 55.9% of those antibiotic treatment they deviate from treatment guidelines in terms of duration, in terms of appropriateness. So that's why we need stewardship. What else we can do? So we can think of new technology. There has been promising result with new antibiotic producing strain in underexplored environment, genome mining with mRNA technology that has reinvigorated natural product discovery field. So that is a scope for future. But we are talking about horizon for the next 10 years. Forward. So whenever you are prescribing antibiotics, you are going to first think about disease as a product of virulent pathogen finding a good environment in a susceptible host. So you need all these factors to have infection. So whenever you are prescribing antibiotic, you are going to think about host factor. So is your patient normal or abnormal in terms of immunity? So if patient is immunosuppressed and patient is sick, you leave everything. They don't have immunity, means they can go downhill very fast. So you have to do something right away. You don't have a luxury of time in determining the antibiotic. So you start with the big guns right away. So comorbidity affecting selection or dosing. So somebody might have allergy, somebody have a renal function, abnormal renal function. So you may want to, adjust the dose of antibiotics. And there are many antibiotics that is contraindicated. You may want to choose that are safer, that is not going to retain in kidney disease. So environment, you are going to ask whether the infection that you are trying to treat is community acquired or hospital acquired. So what makes that likely to be hospital acquired? If somebody had recent hospitalization, or if somebody had antibiotic uses in 90 days, so those are the two things that is actually going to help you in determining those. And then environment also warrants the thought process regarding what are the likely organism, based upon anatomic source or based upon, let's say, gram stain. So let's say somebody comes with a pneumonia and you send sputum, gram stain, and then you know whether gram positive, gram negative. That is going to help you in choose of antibiotic, as does the rapid test, whether they have MRSA in the sputum. So you start on the, let's say, MRSA coverage, and then the sputum comes negative for MRSA, unless there is a good clinical reason to use to cover MRSA. You may want to stop those antibiotics when you have those information. And, and also, likelihood of resistance is very much important. You need to know the local susceptibility pattern. So how do you know that? In Frederick Hospital, Scout page, you can type antibiogram. So every hospital has a different antibiogram. So it's very important to know what antibiotic actually works for the bacteria in that particular hospital. I was pleasantly surprised when I knew that Pseudomonas in our hospital, in Frederick Hospital, they are more sensitive to cefepime than meropenem, and also than Johnson. So that was a surprise, but and that's what it is. So you need to know local antibiogram. Then pathogen factors. So seriousness of infection. So what is the virulence of organism that you are trying to treat? What is the risk of systemic infection, including bacteremia? So those are the things you are going to ask yourself. Then in terms of antibiotics factor, bioavailability of infected at the infected side. So let's say you are trying to treat meningitis. The antibiotic that you chose, is that going to cross blood-brain barrier? So that is a question that you are going to ask. So one of the example I'll give you, cefazolin has been considered an unofficial drug of choice for MSSA. But cefazolin you cannot give to treat brain infection with MSSA because it cannot cross blood-brain barrier in the therapeutic concentration. So let's say somebody from the neurosurgery is actually consulting you for antibiotic uses. You cannot actually give what you call cefazolin. So in that case, nafcillin is going to be the drug of choice in that particular patient. We don't typically do nafcillin. I'm going to talk about why we don't do nafcillin, but in this particular case, there is no option. Broad spectrum and narrow spectrum. So that is another question that you have to answer. Bactericidal or bacteriostatic. If your patient is sick, if your patient has endocarditis, if your patient has a neutropenic fever, meningitis, osteomyelitis, then you may want to use bactericidal antibiotics. And then side effects is another thing. If somebody is already has a nephrotoxicity, you may want to limit the second nephrotoxic agent. So it's really important. So example I'm trying to give, if somebody is on aminoglycoside and is also on vancomycin, and actually you are getting some side effect in terms of kidney dysfunction, you may want to withdraw that vancomycin and can substitute with linezolid if possible. But linezolid cannot always substitute vancomycin. Remember that. Linezolid is a bacteriostatic. Vancomycin is a bactericidal. So there are some conditions where you have to use bactericidal. So that is very, very important to know. So let's talk a little bit about infective endocarditis, since we talked a little bit, we touched about infective endocarditis. So bactericidal agent, IV antibiotics, and antibiotics for long duration. Those are the three principles of endocarditis management. All right. So general principle, very sick people, immunocompromised people, consider broadly, and then follow the rule of three. What does that mean? By day 3, you should have some information about the pathogen. So blood culture that you send might be growing something, or it might not be growing something. So that means if everything is negative, it doesn't make sense just to continue antibiotic when we kind of ruled out the actual source of infection, right? So by day 3 you should have some information, and if none of the information you don't get any information that is suggestive of infection, you may want to discontinue the antibiotics. And then sick and bacteremic patient, make sure patient is getting bactericidal. That's very important. So One of the example is infective endocarditis. So what happens in the infective endocarditis? Why we give bactericidal antibiotics? So if you look at the core of the vegetation, in the core, so let's make a picture here. So this is the vegetation, and then this is the core of vegetation, and there are like billions of bacteria here, right? So basically, if you look at the bacteria here in the core, they are metabolically inactive. So by just giving bacteriostatic antibiotic which just stays here and doesn't do anything, is not going to serve the purpose. So you have to give something that can actually go inside and kill those dormant bacteria. So you need a bactericidal agent. So that is why, giving bacteriostatic antibiotic is not going to cut in infective endocarditis. The second principle why you give antibiotic for long duration in infective endocarditis. So because if you look at the bacterial proliferation cycle, the first phase is lag phase, that is followed by log phase and then resolution phase, right? So this phase, by giving antibiotic for long duration, what you are doing, you're waiting for this dormant bacteria to go into this log phase where the antibiotic is most effective. So, IV antibiotic, bactericidal antibiotic, and antibiotic for long duration. So these are the three principles of, infective endocarditis management. Again, more research are being done to prove these principles wrong in the future, and they are doing research on PO antibiotic, they are doing research on bacteriostatic antibiotic, and they are also doing research on antibiotic for short duration. So that's why we are doing all this research, but for now, 2021, this principle still holds the true. There was a paper that was published in 2019 where they talk about continuing the therapy of infective endocarditis, with PO antibiotic after blasting them with, antibiotic for short period of time. So, there are a lot of studies they are doing, but for now, IV antibiotic, bactericidal antibiotic, antibiotic for long duration. And remember, new is not always good. When you have choices um, with a similar coverage with a different antibiotics, select the least expensive one. That will actually increase the compliance from your patient. So it's very, very important to do that. So whenever you are prescribing antibiotic, we call it stack approach. So stack approach stand for syndrome and context. So what are it? And let's say you have a patient with a UTI. So what are you trying to treat? Are you trying to treat cystitis or lower UTI, or you're trying to treat what you call pyelonephritis? So syndrome and context is really, really important. Whether you are trying to treat SCAP versus you are trying to treat community acquired pneumonia, that's really important. And then you have to target the key organism. So what is the likely organism? So if you are talking about, let's say, cystitis, what is the likely organism? E. coli, right? If you're trying to treat community acquired pneumonia, what is the likely organism? Pneumococcus. When you're trying to treat, hospital acquired pneumonia, what is the likely organism? Staph aureus or Pseudomonas, right? So you have to target the key organism, and then you have to give antibiotic which is active where the infection is. So there are many antibiotic, they don't work everywhere. So I'll be talking about that. And the cidal agent you use for somebody who is really sick or infective endocarditis or osteomyelitis, and then source control is very important. So, poor activity at the site of infection. So oral vancomycin you give, it's not absorbed. And systemic vancomycin is not secreted in the gut in the therapeutic concentration. So IV vancomycin you cannot use to treat C. diff colitis. Cefazolin has a poor CNS penetration. Daptomycin is inactivated by long, surfactant. So you cannot use to treat, staph pneumonia. Micafungin does not get into urine, and moxifloxacin and azithromycin does not get into urine. So these are the classical example. Another example I can give you is aminoglycoside does not work in the lungs. Aminoglycoside does not cross the blood-brain barrier, so you cannot give aminoglycoside to treat meningitis or pneumonia. So these are the limitations, so you need to understand. So targeting key organism, gram positive. When you're talking about gram positive, what is the risk of MRSA? And the gram negative, what is the risk of Pseudomonas ESBL, or what is the risk of CRE? Or anaerobe, if you're talking about anaerobe, what is the risk of above diaphragm anaerobe versus below diaphragm anaerobe? So, and atypicals, what is the risk of atypicals? So pneumonia, right? So there's a chance of bacteria which don't have cell wall, so you have to keep something that works in the protein synthesis, something like mycoplasma, rickettsia, chlamydia, so you need to give something like fluoroquinolone or something like azithromycin to cover this organism, in addition to conventional coverage for community-acquired pneumonia with ceftriaxone. So that's why our protocol has ceftriaxone plus azithromycin, or if it is a fluoroquinolone, moxifloxacin alone. So, and what is the risk of fungal infection? But remember, fungal infection is not rare, especially those people who have IV access and also are on TPN. So whenever you see that, think about fungal infection. Also in a neutropenic people, after 5 days, if they are persistently having fever, think about fungal infection. So that is the time when they start having fungal infections. So anaerobic coverage, these are the antibiotics that covers anaerobe. So you can read the rest, but the key points are above diaphragm anaerobe, are typically covered by clindamycin, and the below diaphragm anaerobe are covered by metronidazole. And then, if you combine penicillin with a beta lactamase inhibitor, so this combination, look here, penicillin with a beta lactamase inhibitor, so it gives penicillin two properties. Number one property is anaerobic coverage, so this is a number one coverage property. And then second property, when you combine penicillin with a beta lactamase inhibitor, it becomes it gets property to cover MSSA. So these are the two properties that you actually get when you combine penicillin with a beta lactamase inhibitor. Penicillin itself does not cover, amoxicillin itself does not cover, but if you combine with clavulanic acid, it's going to cover MSSA. Remember that. So carbapenem, chloramphenicol are the other antibiotics. Then talk about atypicals. You have to give something that works in the protein synthesis inhibitors. So these are the antibiotics that you can look at. And then gram-negative, when you are talking about gram-negative coverage, we're talking about penicillin with beta-lactamase inhibitor, also cephalosporin, anything beyond second generation cephalosporin, they are going to cover gram-negative. Higher the generation, more robust, coverage of gram-negative organism that you get with cephalosporin. Quinolone are going to cover monobactam, Bactrim, carbapenem, and remember, aminoglycoside has a most strong gram-negative coverage, but it is limited by its its property of being polar, means it's a water soluble, it has a hard time penetrating blood-brain barrier. It does not go to the lung, and you cannot actually treat for the pneumonia. So classical example I give you here is cystic fibrosis. Cystic fibrosis predominant infection is in the bronchus, so you can still use aminoglycoside to treat cystic fibrosis patient, but always remember, they are not given alone. You have to give something that works in the cell wall, that works against pneumococcus. So that's why we typically combine what you call cefepime or josin with aminoglycoside when you are treating cystic fibrosis. So chloramphenicol is rarely used. All right, and then so antibiotics with excellent bioavailability. These are the antibiotics. So remember, linezolid has 100% bioavailability. So as long as you are dealing with somebody with a congestive heart failure, and you cannot rely on that, gastric mucosa to absorb linezolid, there is no valid explanation not to switch IV linezolid to PO. Remember that. Rest antibiotic listed over here have excellent bioavailability. So this slide shows you about the mechanism of action of different antibiotic. I got this from medschool.com. So please take time to go over mechanism of action of different antibiotics. So let's talk about penicillin allergy and antibiotic uses. So many times penicillin allergy is labeled inappropriately. People have a history of penicillin allergy, but they don't really know what kind of allergic reaction and when did that happen. And especially if those reactions are minor one, and if those reactions happen more than 10 years, the chance of recurrence is very, very low. Unfortunately, up to 25% of inpatients have a documented um, antibiotic allergy, and mainly if there is penicillin allergy, that's a big loss because penicillin is one of the very good class of antibiotic that has a highest level of bactericidal effect. And if you are labeled allergic, and if you are mislabeled allergic to penicillin, you are going to unfortunately lose a major class of antibiotic, which has a very low side effect profile. And the prevalence of true IgE-mediated allergy among the patient with self-reported beta-lactam allergy is low. And having antibiotic allergy level is associated with increased morbidity and mortality. For patient with history of maculopapular RAS only, we can consider using cephalosporin or carbapenem because cross sensitivity is around 3%. So whenever you see a patient with reported penicillin allergy, you may want to ask more. When did that happen? Whether they had any kind of allergic reaction they have experienced themselves. So that is really, really important. And then if it is more than 10 years and minor reaction, you can actually use um, cephalosporin. And then we do have a study ongoing in our hospital about penicillin allergy patients. So you may want to reach out to your senior resident who will know about the study, because we are doing desensitization in a selected subset of population, because we see that is opportunity to make a difference in a patient's life. So avoid other beta-lactam antibiotics with a history of type 1 hypersensitivity reaction, especially angioedema, anaphylaxis, and also the Drace-Stevenson syndrome or toxic epidermal necrolysis. So these are the major reactions. In that case, you have to avoid beta-lactam antibiotics. So remember, H2NM can be used in a patient with a severe penicillin allergy, unless that penicillin allergy is towards ceftazidime. Ceftazidime has some resemblance to azithromycin. So for that reason, you cannot use. If somebody got anaphylaxis to ceftazidime, azithromycin should not be given. Otherwise, azithromycin has a good coverage. I take it like ceftriaxone for gram-negative, and some pseudomonal coverage, a little bit more than ceftriaxone, I would say, and moderate coverage against Acinetobacter. Um, Unfortunately, it does not have any effect against gram-positive or anaerobe, and it's safe for renal patient as well. So that's about penicillin allergy. Use your resources. Use local antibiogram to guide empiric antibiotics. I was surprised to learn that in our ICU, cefepime is more effective against Pseudomonas than piperacillin tazobactam. So you need to know antibiogram of your particular hospital. Then UpToDate has a good resource. You can follow John Hopkins guide for antibiotic uses. You can also use sanfordguide.com. So let's talk a little bit about MDRO, multi-drug resistant organism. Any organism that is sensitive only to two or fewer antibiotic are called MDRO. Some MDRO, they have their own acronym like MRSA, methicillin resistant Staph aureus, BRE, which is vancomycin resistant enterococcus, ESBL, extended spectrum beta lactamase, and then CRE, which is carbapenem resistant Enterobacteriaceae. So some have inherent resistant to most antibiotic, like Acinetobacter. So these are harder to treat because there are very few drugs available to treat them. Infection require longer and costly treatment. They require extended hospital stay and also require isolation. So there is a lot of economics involved in the management of this organism. However, several old, less commonly used antibiotic, they tend to retain their activity because if you don't use antibiotic for some time, bacteria, they forget how to deal with that antibiotic. So we have a resurgence of this old antibiotic. We are going to use those things. Classical example is fosfomycin. These are being more effective in many UTI cases. And remember, ID consultation should be considered in the management of MDRO. So these are the different kind of antibiotic with the effects on a different kind of MDROs. Remember, you're going to consult ID for final decision making. These are very expensive antibiotic, and you don't want to use this. And use of many of these antibiotics are limited due to infectious disease. And the four core action to fight against MDRO involves infection control practice, hand hygiene, universal precaution. Those are very, very important. And then tracking resistant bacteria, something like surveillance activities at clinical level and at lab level is very, very important. And antibiotic stewardship program is very, very important. And then promoting the development of new antibiotic to fight against this MDRO is something we have to do to deal with this very resistant organism. And these are my references. If you have any further questions, feel free to reach out to me. My email is spaudel@mcw.edu. And thanks for watching.